you are the director of mental health at the state, right?
Yeah.
What is the 1 to 2 sentence summary of the plan?
Our vision for the state, literally, is people with mental health, substance use, intellectual and developmental disabilities, and traumatic brain injuries can thrive in their communities. That's our vision. So the plan is very much about, for each of those populations, what are our goals to make sure people have access to services and supports, and that those services and supports are actually high quality. So we have goals related to folks with serious mental illness, children with serious emotional illness, our crisis system, our workforce, people with intellectual and developmental disabilities, people with substance use disorder and opioid use disorder. All those groups have very specific challenges in accessing services, and the quality and the way those services work in communities varies dramatically. So it's a pretty big plan because each community has their own specific needs and their own specific ways and levers you have for tackling the problems. But the goal's the same. Everybody deserves their best life. Like, it is literally that simple. So we just went around and we listened to the state and said, okay, within people in crisis, what is working and not? With kids who are in out-of-home residential placement, what's working or not? We set goals and we're funding programs we think will make a difference.
Kelly, thank you so much for being here. I'm so excited to have this conversation. I wanted to start with a little story about the first time we met. Last year.
I'm not ready for this. Okay.
And what you don't know about right before we met was I was in the audience watching you give your speech around your strategy for the entire care continuum of North Carolina mental health.
Yeah.
I actually have a picture of the pitch because I thought it was so cool.
Yeah.
And I was really inspired hearing you give that because I had yet to see somebody give such a thorough 100% view of the entire care continuum of a state. And when I went up to talk with you afterwards, I had a bunch of questions in my head about all this stuff, and you had sort of built this crowd of people around you who were wanting to speak with you, and I lost all of my questions just watching you and the way that you interacted with these people. And how attentive and caring you were for every one of the 30 people around you. And when I actually got my turn to speak, I felt that exact same attention. And now that I've gotten to know you a little bit, it's not surprising to me at all why you're so good at what you do because of that. And so I guess the first thing I'd love to just start with is, like, you know, when you got this call about this $835 million investment that had been actually given for mental health in the state, like, what was the first thought?
So first, thank you for saying all that kind stuff. It is hard to sit and hear people say kind things about you. So thank you. And it's been a pleasure to meet you and to get to know you. And I appreciate the partnership. So the $835 million, I think, you know, I hate to say this, but it was slightly anticlimactic. But let me explain why, okay? So we had been working with the secretary and the governor and the legislature for months, kind of devising the ask as well as what we would use the ask for. So my thoughts at the moment were, okay, this is a huge amount of trust that's been placed in us, and we really need to do a good job. So that's kind of where my mind was. Okay, we actually got here. I can't believe it. Now let's be tight. Let's be engaged in the community. Let's spend it. Let's actually make a difference with the money. So I think I was really just focused on doing a really good job with it. So yeah.
Where was the origin? Like, take me back to the start. Like, who was the person who said, we need to do something here?
Well, I think, I've been with the department for, oh my goodness, almost 15 years now. I was actually at the state Medicaid agency working on the mental health and substance use side at Medicaid. And I've had this role for about 2.5 years. And when I came into this position as the director of the Division of Mental Health, Developmental Disabilities, and Substance Use Services, all the letters are really important because they're people. What was really cool about it was, at the time we had Secretary Cody Kinsley, who I'm sure that you know and met. And I remember the very first day I went into his office, and he just proceeded to share with me all these things he was very passionate about and things he thought we needed to work on as a system. So that was really unique for me to have a secretary that was so passionate and knowledgeable about our world. So some of it was his passion for helping folks involved in the justice system, knowing that we had a workforce crisis, and that was one of our priorities, caring about people in the crisis system and needing something better than law enforcement and hospital-assisted crisis. So he kind of had a vision of, these are some really big problems. You know, as the secretary, you understand all the pain points in the system. So these were big pain points, but also passion points for him. And so, but what was great about him too is that he allowed us really to work as a team to say, okay, we hear your problems, we hear your passions. What are the best services and programs that we can purchase with our dollars, and try to convince the General Assembly that'll make a difference. So it was really kind of him as the secretary pointing out problem areas in the state, but allowing us kind of as clinicians and people working in the system to work with the community to figure out some of the solutions.
So when you had the conversation and there was action around, hey, let's go figure out what we're going to do here if we were going to do anything, can you tell me about the process for what the internal wrangling of team was, and then how did you come up with this strategic vision, and how did you even like wrap your head around tackling all of the different problems?
Yeah, and I would say too, when the speech that you alluded to was both about the 835, but also the vision for the entire system. So just to be clear, the $835 million, and I don't want to put a damper on it, but I would say probably about half of that actually came to us for these projects. So, and those were incorporated into our strategic plan for the whole state. But I would say the way we decided to spend the 835, as well as how we came up with the strategic plan for the whole state, that was really, honestly, a lot of it was spending a year getting to know our system. So yeah, that does mean all the ways you're supposed to, which is data and money. What are we spending money on? What is data telling us some of our problem spots are? But then it was actually going around the community, first and foremost, meeting consumers and listening to them and hearing for them what were the greatest challenges for them in the system or things that weren't working right now. But also just listening to other parts of the community, whether it was a Department of Social Service, an EMT, law enforcement partners, our LME-MCOs, which are managed care companies, our Medicaid partners, local health departments. I spend a lot of time in the community because I think that's right. But what's not surprising to me at all is what the data says about where the holes are in our system. Is exactly what the community was saying too.
What was maybe an example of a problem that you were surprised that you learned when you went out in the community?
That I was surprised.
That you maybe didn't know about before?
I think I was surprised. And I guess when you think about where I sit in the system, I'm making my case for why it's important to get to the community. So what surprised me was less, I knew we had people, I'll just give you a problem that every state's grappling with right now, right? I knew we had a problem with people in crisis ending up going to the emergency room and getting stuck there, right? Because there was nowhere for them to go to. So like every state grapples with that, unfortunately. What I didn't know entirely was the whys of the dynamic and why that was actually happening. And so I did learn, because you think, you're at the state, right? From the 50,000 foot level, right? You've got a clinical coverage policy. You've got a funding mechanism for crisis services. You have a contract with managed care companies and therefore providers for how they should behave. But when you go in community, you learn 50% of the people that come to the crisis centers don't have Medicaid and no one else covers it. You learn that counties end up propping up the crisis system or not. You learn that it's real people that are the EMTs and law enforcement and the crisis center, and do they get along and work together or not? You learn how well the crisis team is functioning or not. So you think you have all the building blocks, right? You've got the policy, you've got the funding mechanism, you've got a contract, but the way it ends up being operationalized in the community is subject to so many forces. So that, I think that was a surprise, because I think on paper we look really good. We've got all the tick, tick, tick. You go to Samsung, you ask what are the crisis services you should have. We got them all.
Yep.
Medicaid pays for them all. Tick, tick, tick. But the way they're actually working or not, and also the really the people that are actually coming to them and how they need to be used, that's very community specific.
Yeah, it turns out when people are involved, things get a little bit harder.
Yeah, how about that?
So, you are the director of mental health at the state, right?
Yes.
You are the overseer of everything. You live and breathe this work every day. We've alluded to this strategic plan
Yes.
that you have set forth and that the state is pursuing over the next 5 years, decade even.
Yep.
What is the 1 to 2 sentence summary of the plan?
Okay, the 1 to 2 sentence summary. The plan is, our vision for the state literally is that people with mental health, substance use, intellectual and developmental disabilities, and traumatic brain injuries can thrive in their communities. That's our vision. So the plan is very much about, for each of those populations, what are our goals to make sure people have access to services and supports, and that those services and supports are actually high quality. It's very basic, right? I mean, what I said is not terrifically earth-shattering, but those things don't necessarily exist across the continuum. So we have goals related to folks with serious mental illness, children with serious emotional illness, our crisis system, our workforce, people with intellectual and developmental disabilities, people with substance use disorder and opioid use disorder. All those groups have very specific challenges in accessing services, and the quality and the way those services work in communities varies dramatically. So it's a pretty big plan because each community has their own specific needs and their own specific ways and levers you have for tackling the problems. But the goal's the same. Everybody deserves their best life. Like, it is literally that simple. So we just went around and we listened to the state and said, okay, within people in crisis, what is working and not, with kids who are in out-of-home residential placement, what's working or not. We set goals and we're funding programs we think will make a difference.
Yeah. It's really interesting going back to what you said, which is like every state is grappling with the set of these problems. Yep. I've been fortunate enough now to get to speak and meet with a lot of different state leaders. Yeah. And whenever I tell people that we are working in North Carolina, I get the same response, which is, oh my gosh, North Carolina is amazing and so innovative.
Oh, good.
And I guess what I read into that is like, everyone has these problems, but like not everyone is actually setting out to try to solve them and to actually put their money where their mouth is and then to go and do the work. So like, it sounds like going all the way back to Secretary Kinsley, but then beyond, like, why do you think that North Carolina right now and your leadership and the other leadership that you have at the state are actually taking the, bold action to invest hundreds of millions of dollars to do the work, to create the plan? Why do you think North Carolina is different this way?
Great question. I'd be remiss if I didn't say it means a lot. It meant a lot to me to come into this role and have, it truly means a lot when your governor and your secretary say mental health matters, opioid use matters, people with substance use conditions matter, people with intellectual and developmental disabilities matter. So to get that kind of support is extraordinary, yes. But I would say that I also had the support to do my job. If you look at my job, by statute, it's actually the public mental health, substance use, and IDD system is our responsibility. We're actually required by law to develop a state plan. We haven't had a state plan for a long time for what the optimal system looks like and for the steps to get there. Like, I know that sounds really simplistic, but it's my job, and I want to do the job to the best of my ability. And you know me. That it's personal for me. This is 100% personal for me. I'm a hard worker. I'm never going to do anything halfway. And this matters. It matters tremendously. We are literally talking about people who, for decades, have been at best misunderstood and at worst just treated horrifically. And I'm over that, right? We have to do better. Everybody deserves that. And mental health, just talking about it specifically, 1 in 4 of us have mental health issues. It's just common. It's who we are as humans, and we just have to do better. So, yeah, I mean, having that kind of support, having a wonderful infusion of funding, that sends a real message to people. But then really taking our job seriously. I want to do a good job. And I've got a wonderful team. Like, everybody at my division, I think part of what's fascinating about my division is people have the courage to say they have lived experience. A lot of people do, But I cannot tell you how many of my staff are there because they've got a child with Down syndrome. They've got a sibling who died by suicide. This is why they work there. And so my job is to be their leader, to give them a vision. I think vision matters. It's to partner with the community, and it is to execute to the very best of our ability.
Do you feel pressure to show up as your authentic self always?
Yes, but I don't know how to be any other way. I don't know. I mean, yeah, because I really think, again, if you talk to the people that matter, let's be honest, the people that matter are the people themselves who are struggling with recovery, a substance use disorder, a child with Down syndrome and no services. That's our community. And they expect me to be authentic, but I don't know how to be anyone. They're humans. We're interacting together as people. And what they say resonates with me deeply. I have family members with mental health issues, substance use issues. I've had close families die by suicide. This is part of my life too. And I think saying that has been life-changing for me.
Yeah.
I was a clinician for many years. And what you are taught as a clinician, for good reason, is that you're there for the person, your client, obviously, but you keep everything of yours behind a wall. I mean, they encourage you to get your own therapy in the back end, which I think is really actually wise. But, I think part of that, but also just the stigma and the shame you get from society teaches you just to keep your business quiet. The power I feel like I have and the connectivity I feel like I have with the community by admitting for the first time in my adult life, yeah, I was raised by someone with a serious mental illness. My childhood was rough. I've got lots of family members with opioid use disorders and substance use disorders. I think that helps me heal. It's kind of extraordinary. And it really helps me connect with the community. No, it's not all mushy feeling and whatever, but being authentic, I think, means a big deal. But it also means, I do think it makes me more attuned, I hope it does anyway, to saying to people, what kind of system do you need? What do you need? How has the system failed you? Where has it been good? Let's do more of that.
I think it's hard to ask people to be honest about their experience if you haven't been.
Yeah.
And I think especially when you have someone like yourself in a true leadership position where you are, in a lot of ways, the decision maker, the example that you set, I think, trickles down. And I would even say the example that, Secretary Kinsley set, this is a state in a weird way that has a lot of bipartisan challenges, but has a lot of bipartisan support for this issue.
Yes.
And in a way, it's when you have all of those things supporting the forward trajectory of mental health, of people being open about it, and you have someone like you who is open about it, and you actually have an opportunity to go to the communities with credibility and say hey, we're actually here to help.
Yeah.
And I feel like what I've seen too is when you go into a community that you don't necessarily know super well, even if you're there to help, in a very deep and honest way, if you don't have that connection by either the shared lived experience of the living in the community or of a mental health issue, it's really hard to get people to get on the same page, even when you're trying to help. So I wouldn't discount how important that is and how important the authenticity is that you've brought.
Yeah.
And I expect that this sort of seeps into all of the work that you do.
Yeah. Well, I really appreciate your perspective, and I appreciate you saying that. As you were talking, I'm thinking about I think the other thing that's just as important is, and I won't even say it well. I'm trying to make sure I say it the best way, but I've been really struck lately, it stood out to me when people seem to approach our community with, I'm here to help you. And I really think that people can and do help themselves and should be afforded every opportunity to do so. I think if we build that system, we're going to be good. And I think sometimes, when I talk about my own experience, I was worried that because it's true. Every time I talk about my own family or my background or my friends, I know that there are people in the audience who are going to make assumptions about me, not good ones either. They'll say, oh, she's emotional, she's weak. Oh, they'll be looking every time I say something wonky. Oh my gosh, she probably has bipolar disorder. Whatever, so be it. But it's true. You face that risk all the time. I think it's worth it. And I also think what I hope to show people more than anything is it's okay, be who you are, love who you are. But the other message I tried to carry about my friends and family is that very few of them had formal treatment. And they're living lives. That's not me saying don't have formal treatment. I'm a clinician, right? I think the best treatment helps, and it educates folks and it makes them feel accepted and loved and shows them that they can recover themselves. So I think that it's important that people hear that people with mental health, substance use, intellectual and developmental disabilities can live full lives. They can be in charge of their own lives. They don't need other people helping them per se. If they want help, that's fine. But if they don't, that's fine too. So I think that idea of personal recovery is really important.
Can you talk a little bit about how your experience as a clinician?
Yeah.
There's not many clinicians who ascend all the way to leading the entire state mental health care continuum.
Yeah.
How did your clinical time and experience of actually seeing patients one-on-one, how has that informed how you show up today when you're directing all of the bucket of services?
It helps a great deal. And I don't mean to please don't hear me like critiquing people that maybe don't spend time in service delivery or don't have their own lived experience and come and work in the state. Lots of people are brilliant and have passion and do great jobs. You don't have to have those things. But I think as a clinician, I really do, in the most simplest way, I started as a clinician before I went to the Medicaid agency, and my job at the Medicaid agency was Medicaid coverage policies. It was powerful for me to have been a provider trying to work through those policies to see how they worked or didn't when you were trying to provide therapy or services to people. So I think that was a big deal for me at the most basic of ways. But also, one of the things that will always stand out for me at being a clinician, a couple things. Like, I realized that the people that came to see me were largely uninformed about mental health issues. They were full of kind of the stigma and bad messages they got from people. So even if it was something as simple as their child had ADHD, they themselves had a depressive episode or had a generalized anxiety disorder, how much they didn't understand about actually a pretty simple diagnosis. Depression is so common and the symptoms are so normal. So just being able to normalize and educate people, I think, is really important, and I think it gives them a lot of power. So that was a recurring theme across the board, that shame, stigma, and misinformation really, really screw up the trajectory of health and wellness and recovery for a lot of people. So I learned that a lot from working with consumers. I also learned all the ways the system doesn't work for them or providers very well, right? Things that are unnecessary.
Can you give some examples?
Yeah, I was going to give you an example, actually. like even something like, we should have a person-centered system, right?
Yep.
I'm going to get in trouble for this one. I need you to know that. We have something in North Carolina called a person-centered plan. Do you know what that is?
I don't know.
So a treatment plan, right? And when you think about when you go to a MD, right, you get your primary care doc, they put a treatment plan for you. It's like one sentence and thing. We have this elaborate thing called a person-centered plan that you've got to fill it out, and what are your goals and what are your strengths and what do you want to work on, and it has to get signed by 4 people and in black ink only. And it's become this like arbitrary thing that in no way drives person-centeredness. And we try to teach people how to do the plan really well. But it's definitely an example of, we tried to use an administrative thing to make our system more person-centered, and we missed the mark entirely. So things like that.
What did you learn about actually delivering person-centered care from that experience?
I do think, like, if we spend time training people on the person-centered plan, we miss the forest through the trees. We're not teaching them about recovery. and what true person-centeredness actually means, and how to genuinely connect with the people you're supporting and ask them what they actually want. That it's actually as simple as that. But I also learned too, as a clinician, one of the things truly that was hard for me transitioning here was we have a very different model of care than I'm accustomed to, and perhaps I came from a bounty of riches. I practiced in Pennsylvania and New Jersey, and we have lots of licensed clinicians willing to serve in the public system. When I came to North Carolina, we had many years ago, we have the issue that states face now, which is there aren't enough licensed clinicians willing to come to the public system. So we allow non-licensed people to provide services. And there's nothing wrong with that. But the reality is they don't have the training, knowledge, skills, and experience that people who do get training and intensive supervision do. And I think you notice a difference.
Talk to me about, you mentioned as you were analyzing the state and you were looking through the different problems.
Yeah.
One of the ways that you kind of cross-cut it was SMI, youth, some other populations. Talk to me about the youth population.
Yeah.
What did you identify in that research project as the biggest challenges, the biggest areas of need across the youth population?
Wow. Youth, that you would pick the hardest one, of course, but I know that is
our world.
Yeah, right. And I'm grateful that it is, right? I'm super grateful that it is. And your model, you can see why it resonates with me, right? It's very much about putting the kid in the driver's seat and using peers and life experience. So that's why it resonates so well with me. But kids. So our plan, you will see, is focused on kids typically at the most complex end of the service delivery system, right? Because we're the public system, we're the safety net. And so what we've been hyper-focused on in the child space are the kids who end up stuck in emergency rooms with no place to go, who often have long histories of trauma, who do have problems regulating. That's the fancy way to say these are the kids sometimes who will act out very assertively or physically, understandably so. And kids who end up in out-of-home residential treatment placements, sometimes just for months on end in multiple placements for treatment, if you will. And so so doing a really deep analysis of who those kids are is pretty telling and how they got there. So when you start at the deep end of the ocean, you really see how, there are thousands actually of kids in the deep end of the ocean who, and we're working actually really hard right now to reform that system. In my perfect world, kids would all come home tomorrow. That's not realistic, and we don't have the community arrangements for them. So we're working really hard to work on that. But now we're trying to look at the front gate for how kids get there in the first place. And did we do everything we could to wrap around the child, which is actually more cost effective, but also, good, but also more clinically. I don't think there's any amount of money that's too much for a kid. I need you to hear me say that. So I said cost effective because I'm supposed to, but really it is, it's a kid. Yeah. Is there really too much money you could spend to keep a kid in the community with wraparound services? I don't think so. So we've learned a lot there, and so we're working collaboratively across the department to build everything from more foster homes and more family-based services and crisis services for kids, right? So they don't end up in this deep end of the ocean, I keep calling it. That makes it sound way better than it is. But another thing that we're doing, which is actually our number one priority, which is about access in the system. One of the things I've really enjoyed doing, actually, and part of our partnership with you is, it's hard to even put a number on the number of kids who could use some mental health supports across the state. So we have also focused on things like school-based services. We have a couple of telehealth projects right now that we're exploring because technology in kids works, and we'd be silly to not use it. Talkspace we offer statewide now. And those are kids that we're hoping to get before they end up in an emergency room or in I don't want to say in need of an out-of-home placement because I don't think there's a need, find themselves in an out-of-home placement because that's the only thing the system can provide for them at a certain point in time. So access for us is very much about everything from advertising 988. Our number one group of people reaching out at 988 are 12 to 19-year-olds. Doesn't that take your breath away? So we've done good at marketing to them. Chat, call, and text, they're the number one group. We're working really hard now just to make sure that we can get them into immediate kind of lower level services like something. So let's get them something right away. It takes a lot to call our chat. Let's get them in services right away. And we're also just trying to focus on things like mental health wellness in schools and mental health first aid. And just we're working with the YMCAs on like healthy places and spaces for kids. Because I have to. Like, it is my job, and I care desperately about the kids with the most complex needs. But we've got to get upstream as much as possible. I'm going to point out the obvious thing that I haven't said, right? When I said kids are the most complex things. So they're the most complex things because they live in families. So that is obviously the hardest thing, right? That's absolutely the hardest thing. And so a lot of the work, too, is on everything from parent peers. We're trying to get parent peers so they can help parents get through parent education, and also really treatment that focuses on family dynamics rather than what we often do. We vilify the kid. That's probably a strong word, but it's true. We label them with a behavioral health. That's why I don't like the word behavioral health condition, and make them the focus of care rather than whoever that family is. And I applaud kids for who have to find their own families. That's fine.
Yeah.
We'll work with whoever you identify as your family to help you.
Yeah, the stories that I've heard from some of the people who work at the hospitals, both here and then on the western part of the state, where a family will bring their kid who they say has ODD because they had a battle with their parents. They get dropped off. Mm-hmm. Like you said, these are the kids who are getting stuck in the ER for months because there's nowhere to send them. It's really horrific. And
it is.
This is I've been reading a lot from Senator Bergen, who has been very involved here as well, and that was one of the things that he said opened his eyes up of like, wow, these kids are sitting in an emergency room back corner with no windows. It's not the place for them. Yeah. And I've heard you actually say now that I don't know if this is a actual stated goal or if it's just a goal of yours, but it's no PRTFs, it's no out of home placements. Yeah. You also said that you're not sure if that's plausible. Do you think that's actually possible?
I do, but it is something that will take a long time. That's why when I say it, I say in 10 years.
Which is still a very aggressive
It is,
goal.
Isn't it? It is. It is. And maybe in 10 years you don't make your goal, right? But working towards it, I think, is really, really important. I think, and I have asked, right? We work with lots of researchers. We're blessed to be here and, with so many research institutions and folks who do really good work on for kids, right? Kids and treatment models for kids. It's actually hard to find literature that supports those types of settings as beneficial to kids, right? But again, I welcome if folks can say, like, actually, this is a really good residential model of care. And I appreciate that sometimes kids, anyone, not just children, but people could need a hospitalization or some time for stabilization. And depending on your level of trauma or need, it could be 6 weeks. It could be 8 weeks, and that's okay. That's really different than now you live in an institutional setting with no family or friends, and every day is a treatment model of some kind. That's really different. Yeah. And so I think as much as we can for kids, right, we should let kids be in community with grown-ups, whoever those grown-ups are, that care about them and help them, and they can go to school like other kids, and they can have fun and activities like other kids. So yeah, I mean, it's certainly not to vilify residential providers. We need them. We're working with them now to make sure that they're making the most pleasant, safe, therapeutic environments for kids who we have. But ideally, I think it's a little bit hard to argue with the idea that we'd prefer to have kids in a home, in a community. I'm not sure how you could argue with that. It's very artificial. Like, who wants to live in an institution? I mean, that sends a pretty clear message to a 13, 14-year-old kid, doesn't it?
Yeah, something's wrong with you.
Yeah, I don't want to be that. There are states that do not use out-of-home placement. They're few and far between. But again, when we meet as states, when I meet with my fellow commissioners, we're all grappling with kids in emergency rooms and kids in out-of-home placement. So we can all do better.
Talk me through that, because I think it's really interesting that not only are you plugged in here across the community, you're also plugged in across the nation. Who do you look to for inspiration? And then let's start there. Who do you look to for inspiration?
Well, I look with envy at states who are perhaps funded differently, and I'm not kidding. Like Massachusetts, for example. One of the things that we're concerned about here is being able to maintain our mental health crisis system, which we actually think is important. Massachusetts has a law where all insurers have to pay for crisis services, which is kind of huge. And they have a tax to actually pay for things like 988 and crisis services. So I envy that very much. And I think that's the funding mechanism you really need in a state. But I have to say, I've got a lot of wonderful colleagues here in our region here in the Southeast. So do a lot of collaboration with Kentucky. Our anti-stigma campaign for opioid use disorders, we actually got from our friends in Kentucky. They do some really cool stuff around opioids. And when you look at the demographics of Kentucky, it's a lot like North Carolina. Our friends in Tennessee do wonderful things. So a lot of what we do is in South Carolina. And what's interesting is that we don't all have the same politics by any stretch, right? We're all grappling with the same issues, but I really like, for example, what Kentucky's doing in the opioid space. I really like what South Carolina is doing in the crisis response space with empath units and critical access behavioral health centers. So I do find a lot of inspiration from working with my colleagues in our region, but also when you go to our national conferences, like Rhode Island, we got some great ideas from Rhode Island about how to manage mobile crisis for kids in particular in EDs. It's tough though. And the reason I keep tracking back to our region is because although I'm in awe of what Rhode Island is doing with recovery communities and recovery workplaces, we really want to steal that from them. And third spaces they're creating in libraries with telehealth, also want to steal that from them. The size and scope of Rhode Island is dramatically different than us. So that's a good example of, you'll see that in our strategic plan. I'm just enamored with the recovery communities and the third spaces. Translating that into North Carolina, we're still trying to muddle through. But doing something that Kentucky's done with our opioid settlement dollars like us makes actually a lot of sense because they're quite similar to us. Same thing with South Carolina and their empath units. Demographics, funding, very similar to what we do in North Carolina. So, yeah, connecting with sister states is really helpful.
Yeah, it is really interesting to think about the political landscape, also the problem landscape, because every state's probably going to have problems that are slightly more accentuated than others, which will dictate, who has been affected by it at the state legislature and who finds it important. I bet there's a lot of interesting dynamics there.
True.
If let's imagine, I'm going to pick on a state. No shade on Idaho, but I'm going to pick on them here. Let's say that the director of mental health at Idaho says, Kelly, I need your advice. What should I do? What would be the 2 or 3 pieces of advice that you would give a new director of mental health?
I would say the 2 things I think that are actually most important for me that I tell for Idaho is really connect to your community, be trusted, and trust their advice. And I would say organize yourself. I'm not kidding. Our world is quite challenging, and we make it worse for ourselves if we're disorganized. We don't do things in a planful fashion. We don't use data. We don't make smart financial decisions. We can't justify our work. That's critical, I think, to be successful. It's hard. It can be hard to be a social worker and to be you're the mental health person always talking about your feelings. I am, because I think that's a strength. I don't think that's a weakness, but I promise you we will back it up with the data, with the financials, with a well-executed plan. So to me, be the touchy-feely, but also be clean and execute.
And what about tactically? When you're talking about building the care continuum based off of the problems, let's say the problems are the exact same. What are the things that you have learned about starting to tackle these problems?
That is hard because I think that many things, I was thinking of the crisis system, but obviously whatever decision you want to make is going to vitally change something for someone else or cost them money. So I think it's really important before you go out and say grandiose things or even try to do things, you do a good job of understanding the key players in the landscape first. Because something that also happens in our field a great deal is you go out thinking you have a great idea, and then you go to the community and find out they've been working on that for 4 years.
Yes.
That's that's dumb. It was a waste of your time, but it's also a bad look. You really didn't get to know your community and your partners. But I've been surprised. I've genuinely been surprised where I've assumed, like, well, we're on the same side. We all think this is the right use for the dollars. And it wasn't, because they're from a different interest group and they had different considerations that it never occurred to me. But I do think, like, working with the legislature, there are certain things that we all care very much about, right? We may see it in different ways, right? I care deeply that people with mental health needs don't get driven to the hospital in the back of a police car. I care that they're treated with dignity and respect, and they're not afraid when they go to the hospital, because they won't go back. And they might hurt themselves instead of going back. They need a calm environment. I care about that because that's the right thing for them. And I think about the trauma and the potential ramifications for their health, safety, well-being, and recovery. Maybe when I'm talking to legislatures, I don't talk about that at all, but I do talk about the fact that that's not what the sheriff wants to be doing.
Yeah.
Sheriff does not want to be driving folks with mental health issues in their car. And the hospital, too. They would much prefer to deal with stroke and accidents than trying to find a wing for someone in mental health distress. And mental health distress is really different. One person may be depressed, their spouse died, 65 years old, and then you may have a 35 who's, actively hallucinating. And so that's hard. It's hard for a hospital to manage all that in one space. And they don't want that either. So we have lots of common ground. It's the solutions aren't always the same. I mean, the kid thing, that's a hard one. Yeah. I mean, even today, you'll hear people saying we just need more facilities. I hear it all the time. I hear kids are in the ED because we can't find a facility to take them because their needs are too great. And I'm thinking, kids should never end up in there in the first place. And let's all try really hard to find them a home with wraparound supports.
Yeah, it feels like that is just a true inversion of the paradigm of how you were trying to get people to see this problem. Like, we cannot solve it by just backfilling, because the top of funnel is going to continue to increase. We have to invert it. Yeah. And it also sounds like, I mean, you've said this many times, even though you want to get rid of the PRTFs, the out of home stays, that not right now. We can't, until we have these things, we can't just get rid of them, because then there's, that's not a good outcome either. One thing you said, that
cool things to take care of those kids though in facilities. So okay.
Yeah. No.
We didn't forget about them.
We don't want to forget anyone.
No, we don't.
Maybe that is actually the tagline of the NC-DHHS.
No person left behind.
No person left behind. I love it. The funding mechanism at the state level, I think, is really fascinating.
Yeah.
And the paradigm of North Carolina as a state investing so much right now, but it also sounds like, in your eyes, that's not the perfect end solution. The perfect end solution might be different funding mechanisms that sound like they are more sustainable.
Yes.
Right. So
absolutely.
What is your long-term vision for how this next decade of investment rolls into something that you don't have to go fight for again, that it just becomes, the thing that exists across the state indefinitely?
Yeah. Fantastic question. And I keep tracking back to the crisis system. I don't mean to, but it's the best one to give you a true example of the crisis system, right? So part of the issue with the crisis system is it can be quite local, which leads to inconsistencies and inconsistent funding. And so part of when we were investing in actual new facilities or upgrading facilities, we have 12 new urgent cares. We have 100 new crisis beds in the community, not hospital beds, community crisis beds. And long-term sustainability of that is incredibly critical. So, of course, like, I literally am coming from a meeting with Medicaid where we were looking at all the financing data and talking through the crisis utilization patterns we see and what's the right Medicaid rate to pay for the Medicaid folks. How many are left in the safety net and how many are left who have other insurance? So then the strategy becomes, what's the long-term state dollar use and how do we earmark it for crisis? Or is there an ask for long-term? And that's the money that fills in the gaps, right, for people without insurance. But how also do we have a law, maybe like Massachusetts, that says all insurers have to pay to have this model available in communities, right? We have EMTs available in communities. We have 911. Why don't we have something for mental health crisis too? So last year was planting the buildings. This year is finishing out the opening and the ribbon cuttings and all the good stuff. Simultaneously, we've been working on the long-term funding mechanisms for this system. We didn't want to create something that, why would you fund something for it to die in 2 or 3 years? So we knew that from the beginning. We knew, well, we had Medicaid. We do have state dollars to fill in the gaps, but ideally we would have other insurers, maybe a little bit of tax, and it would be a good system. But we're pairing that, just so you know, with data and an evaluation of the system, because we also shouldn't invest in a system that doesn't work.
Yeah.
So this year's about financial sustainability in a model, quality and measuring quality in the system to see if it's doing a good job, and then using that to make choices and changes if we need to.
Is your team overwhelmed by all of the things you're asking them to do?
Yes. Sometimes. Oh, no, I didn't get into this, but when you asked me about Idaho, when I say be clean and have a plan, part of what we've actually been doing, and part of the reason for the strategic plan, is to get rid of baggage. Like, we tend to, many people do, this isn't unusual, kind of sow a field of 1,000 daisies. That's my least and worst favorite saying. But part of our strategic plan was trimming down in-house what our true priorities are. And that means sunsetting maybe fun things that are nice to do and saying, we don't have the bandwidth as a state, nor will we ever have unlimited amounts of money. So what do we have to focus on with our time, energy, and money? And even ask to the General Assembly and ask to our friends over at Medicaid. We've got to be tight and have a vision. And so we've been working on that too. I don't want my staff to be overwhelmed, not at all. I want us all to be passionate, have a joint vision, and unfortunately, especially in this day and age, focus on the most impactful things that we actually have to focus on.
Yeah.
That leaves maybe less time for fun things. But I think it's all fun.
Hopefully building a better system is fun.
If we have a more stable system that absolutely opens us up, like federal grants, we would love every year to give $4 million out in community grants.
Yeah.
Just to community support agencies. We did that last year. And I think the better we are, the firmer we are in terms of financial sustainability and also performance of the program, it absolutely allows us then to be innovative and try innovative things.
Yeah, it's another interesting thing going back to the idea of cost is ultimately the state is going to pick up the burden for a lot of these higher intensive services that are super expensive. And so if you are more effective at all of the bundle of things going upstream in theory, there should actually be a reduction which allows for resources to continue to reinvest. And it's not different from, a business reinvesting resources and efficiency just at the level of an entire state's mental health infrastructure, which is a very interesting problem.
Yes, it is.
Man, that's the TLDR of this conversation. A very interesting problem. How did becoming a parent change the way that you saw your desire to make an impact on the world?
Oh, wow. That's tricky. I'm rarely at a loss for words, as you know, Patrick, but I think about, my son teaches me things every single day, and I've been surprised by what he teaches me in terms of, I can't figure out how his generation is more open-minded, yet as narrow-minded as former generation. It's very strange. He's very, he's a raging feminist. I love my kid. He's just a raging feminist. He's wonderful. And he doesn't even realize that's who he's being. He just is loving and accepting and thinks we shouldn't objectify women. And he's great. And he had inclusive classrooms. He always has. So he's always had kids neurodivergent and with physical disabilities in his classroom, and that's the way it should be. And I remember coming into this job and explaining to him what it meant for someone to have Down syndrome and how the world would put people with Down syndrome in institutions. He was utterly horrified. So I'm encouraged, and he makes me want to keep focusing on a better, more inclusive, tolerant, hate that word even, just inclusive and accepting and loving world for everyone, where we can talk about mental health. Even practicing with him on, 12, 13-year-old who's trying to navigate the world in puberty. He's going to be so embarrassed that I said that. And you're being able to talk about mental health and the fact that you feel depressed and what are some ways to deal with it, that's really helpful for me. And it's helpful for me to think about how do we translate into that in the bigger system. But also seeing what he still grapples with is unreal. Like, I'm like so excited. Woo, we have a much more open and inclusive world where we talk about our feelings. Oh my gosh, there's still massive amounts of bullying and what is social media doing to kids? And it seems like in some ways it's the same old things that I struggled with myself and generations before I struggled with in terms of fitting in and belonging and loving yourself. So I think, believe it or not, that my son keeps me grounded on the upstream wellness. I think, honestly, in ways that I think my division was not used to in their director.
Why is that?
Because we are the safety net. We focus on the kids in out-of-home placement in crisis. We do. But I think we also have an obligation to the rest of we do set tones for all of the state. We're not just for people with Medicaid or who are uninsured. 988's for everyone. Being able to talk about mental health and have resources like Some Things for Everyone, it's for everybody. Reaching out to kids in schools, working with Blue Cross Blue Shield. We work with them now. I don't cover Blue Cross Blue Shield, right? But I want them to have a great mental health benefit for their kids, right? So I think it's made me focus on all North Carolina. All kids need stuff.
Why though? Like, why did he show you that was?
Because I see what even a kid in a home with two parents who just adore him, I see how hard it is to be 12, 13, and 14. The world is a hard place. And he's a kid who went through COVID, right? He went through the virtual school for a couple of years. He went through a very real, I remember when he got COVID 2 years after, right? And he was vaccinated at that point even. It was 2 years in, right? That's when I don't know, it's when we all got COVID. We all got COVID 2 years in.
Yeah.
He was afraid. That was a sobering moment for me. He was afraid he was going to die.
Wow.
You forget. You forget what the psychology of a young person is like. You know, because you're in your 40s and you get it. You're different and you're resilient. And so seeing the world through his eyes and that it's hard for every single kid makes me want to support every single kid in North Carolina as much as I'm able to, right? It's a balance.
Yeah.
So yeah. But I would have to say my experience with, I'm not just a mom, like I'm a sister and I'm a daughter dealing with the more serious end of the spectrum. I feel like that is what pushes me to advocate and demand a better system for people with SMI, which is our core mission. I just think we're better at our core mission when we just try to make the whole state better.
Yeah, I love
upstream. I know we say that all the time, but we have to do it.
Leading is repeating. You're going to have to repeat it over and over. You were recognized this year as the North Carolina Social Worker of the Year.
Yeah.
I don't get the sense that you're a person who reads too much into awards. However, I wanted to ask, what do you think that this honor meant to the work and the philosophy and your vision of what you're trying to do?
I was so surprised and so touched, I'll be honest with you. It means a lot. I'm proud of the fact that I'm a social worker and what that means to me. And I'll be honest, I don't know how to be anything but Patrick. I was like, and please, Valerie, if you ever hear this, please know this is me, not you. You know Valerie, the ED of NASW. I had the doubt creep in my head, like, well, that's just because you're the state mental health director. It's not anything that you did, Kelly. It's just sort of what we do sometimes. We acknowledge people in positions. And that might be the case. But I like to think it's because I try to represent the values of social workers every day. I hope that's what it meant. So it meant a lot to me. Pushing all the self-doubt aside. I don't talk about it a lot because it's kind of, I don't know, it feels really braggy, but it's in the top 10. Yeah.
Love it.
Is. Yeah.
You should be proud of the work that you've done and the philosophy and everything that you're trying to do here, because there are not many people who are both in a position like yours who have the skills and the lived experience and the desire and the passion and the hardworking nature. So thank you for what you do. Thank you for this conversation.
Yeah. Thank you.
Really appreciate it. And
Thanks, Patrick.
Awesome.